I'm going to admit them in now, John. Hello, everybody. Just waiting for everybody here to connect to the audio. Looks like the majority of which are doing so. Fantastic. So welcome, everybody. Thank you all for joining us today and taking an hour out of your busy schedule. I appreciate how busy everybody must be at the moment, given circumstances. So we will try and keep today's session to be within the hour. Just a few ground rules very quickly. We will be keeping everybody muted to enable John to get on with the presentation. We would like to request any questions that anybody does have throughout the seminar to please post them in the group chat along with your name and organisation, and John will try his hardest to get around to all of the questions upon conclusion of his presentation today. A couple of notes that the presentation will be recorded today, and a opportunity to download that recording along with a feedback form will be sent out to all of our participants from this edition of the workshop and the first edition of the workshop, which took place 2 weeks ago, will be sent out. So without further ado, I'll hand over to you, John, to start the presentation. Thank you.
Thank you, Jamie. Hello, everyone. For those of you who don't already know me, my name is John Sandham. I started my career as a bench technician in the Royal Air Force, maintaining medical equipment. And after leaving the RAF, I set up my own business, EBME Services. I went on to become a chartered engineer, professionally registered through the Engineering Council in the UK. I am a fellow of the Institute of Healthcare Engineering and Estate Management, and a fellow of the Institute of Work-Based Learning at Middlesex University, where I'm also a visiting senior research fellow. I'm also a member of the Institute of Engineering and Technology. In 2001, I was co-founder of the Electronic and Biomedical Engineering website, www.ebme.co.uk, which we set up to be a free online educational resource. This free resource is used internationally for the sharing of knowledge with clinical and biomedical engineering community. I also co-founded the EBME seminar in 2009, and I've been honoured to be the chairman since it started. But unfortunately this year, due to COVID, we had to postpone the EBME conference and exhibition. Fortunately, we now have new dates in 2021, as shown on the slide. The EBME Expo is now going ahead on the 30th of June and 1st of July in the Marshall Arena at Milton Keynes, and I hope to see you all there. I would like to say how proud I am of our community for the way in which we have pulled together through this pandemic to ensure that medical equipment was kept available for clinical use in the right place at the right time. Well done, everyone, for all of your hard work. I'll just let you know that you do not need to make any notes from the slides, as they are already available on the EBME website, and I'm happy to welcome you to this EBME Expo webinar, where I will be discussing equipment strategies for operational transformation. The complexity and size of the life sciences industry in the UK is often underestimated. And with an annual turnover in the UK alone of £4,675 million, it is much larger than many people realise. The life sciences industry employs 248,400 people in the UK. Approximately 127,400, or 51% of the industry total, are employed in the medtech sector, comprising of the core medtech and the service and supply segments. The core medtech sector is the largest in the industry by employment and number of businesses, with a total employment of 97,600 people, representing 39% of the industry, and 2,730 businesses, representing 45% of the industry. Core MedTech includes all businesses whose primary purpose involves developing and producing MedTech products, ranging from single-use consumables to complex hospital equipment, including digital health products. This snapshot of the UK life sciences industry gives an indication of the scale and complexity of an industry that healthcare organisations have to deal with on a day-to-day basis. Trying to decide which products and which services to purchase in order to reach a strategic goal, such as connected care, is extremely difficult. To build a picture of the complex nature of NHS inventories, I have put together a couple of slides showing asset holdings and grouped average values. The average healthcare organisation holds a wide variety of devices that may range from low volume, high value items such as magnetic resonance imagers worth over £1 million to high volume, low value items such as non-invasive blood pressure monitors worth less than £1,000. This graph is a visual example of an NHS acute 500-bed hospital inventory broken down by value. The choice of what items to buy is often based on age rather than having a replacement plan that is linked to long-term operational business strategy. In my experience, organisational cost pressures can be offset by investing to save. Investing in the right technology at the right time should be linked to your long-term transformational plan, which will then deliver planned operational improvements. It is common practice in most healthcare organisations to focus on capital assets. This is because they are the most expensive portion of the overall asset holding for a typical acute hospital, representing 85% of their technology spend. But these assets are only 15% of the inventory by volume. Capital assets are subject to more stringent financial rules than lower value items under £5,000 that represent 85% of the items by volume. Devices like defibrillators, infusion pumps, and patient monitors are often not considered a priority for replacement, but they do offer an excellent opportunity to improve organisational efficiency and the future health of the nation. Therefore, any asset replacement plan should include both capital assets and assets under £5,000 when preparing equipment replacement plans. These plans go hand in glove with the strategic goals of the organisation. When buying any medical technology, Health Level 7 or HL7 data transfer capabilities must be considered as essential if the ambition of your organisation is to ensure that device data can be transferred automatically and immediately into the electronic patient records, thereby improving data integrity. To give you an idea of the complexity that the NHS is facing and the costs involved, I've put this graph together, and it shows that the NHS has 880,500 medical technology assets with an estimated worth of £4.65 billion. In my experience, many assets are often kept in operational use long past their manufacturer's recommended life. This ultimately reduces spend on technology, but it does not improve the efficiency for the organisation and does not help clinicians to see more patients or make better clinical decisions. One question I often ask NHS executives is, what if a lack of investment in technology stops your organisation moving forward with its long-term plans? Many NHS organisations have aspired to use technology to revolutionise clinical care and their organisational efficiency, but many years later, they are still managing and investing technology in the same way they always did, and therefore their aspirations do not become a reality. The UK Health Secretary, Matt Hancock, recently said it will be critical for the NHS to work with the private sector to continue an uptake in the use of technology such as telemedicine, especially after COVID-19 has subsided. Expert private sector support will be essential if aspirations are to become a reality. The shift towards digital technology has led to closer working with private sector partners, data-led decision-making, and telemedicine projects. The only possible way to bring all of these new technologies into our healthcare organisations is to have political and financial support for investment in new technology. Matt Hancock is saying that the government is advocating investment in new technology and funds are being provided. Ultimately, healthcare organisations must have executive buy-in from the chief executive and the board of directors for this type of strategic vision to become a reality. Matt Hancock recently said, when speaking on the future of the NHS, we've seen an uptake in the use of technology like never before. I'd say these three big areas where I'd say three big areas where there's been an improvement is telemedicine, data in decision making, and the teamwork between different institutions. He went on to say, we need to entrench these improvements. At the moment, there are cost pressures on the NHS to save money. With the current asset holdings of £4.65 billion, the NHS really needs to be spending 10% on equipment replacement just to maintain the same levels of technology. Higher levels of investment will be required to deliver Hancock's ambitions of a technically efficient NHS. The current NHS annual spend, just to maintain its current position, is a staggering £877 million. This does not include the further investment required to bring more advanced and connected systems for the future. Historically, there have been many serious injuries and deaths involving medical equipment failures and misuse. I read that approximately 5,000 people are seriously harmed each year and over 300 die due to adverse incidents involving medical devices. To counter the risks to patients, politicians have introduced many regulations and standards. These regulations and standards are intended to focus the minds of the senior management on good governance, but there is also an opportunity here to promote the use of new technology with the trust executives to reduce risk and improve clinical decision making, thereby also assisting with the governance. Senior managers and directors within healthcare organisations are primarily concerned with delivering healthcare, but must do so within very tight budgets. This often makes transformational changes difficult because to deliver transformational change normally requires investment in new technology, people, and processes. Organisations that are already financially and operationally stretched will not want to make too many changes. This is why it's important for the executive management team to appoint a director or board member to be responsible for medical devices and transformation. If there are clear lines of accountability to the board, it enables the board to make informed decisions about investment in technology and adopt a long-term approach for management and investment in technology. The MHRA states that the board should be responsible for its medical devices management. Many NHS chief executives are now realizing that new medical technology is necessary to deliver improved efficiencies and better clinical outcomes, whilst also managing costs. There are some forward-thinking trusts such as the Royal Free NHS Foundation Trust in London and Cambridge University NHS Foundation Trust that are pushing hard to deliver modern technological solutions, which are being championed by their chief executives and their boards of directors. Creating strategies for operational transformation require only two things to be in place for a successful strategy: the right stakeholders to be engaged and a forward plan outlining the business, growth and direction of the organisation. This will allow the equipment management strategy to be aligned with the organisation's operational plans. Often, 5-year operational plans are not plans at all. They're only dreams. This is because although the executive team know where they want to go in 5 years, and they can also write it down, they have no route map on what they actually need to do, what they need to spend, and what external support is required to make their vision a reality. Transformational plans require the executive team to be on board in terms of leadership, investment in new technology, and also investment in people to deliver their objectives. Their plan needs to be led by an experienced project manager at the helm, with possibly a project team assisting, who will bring together all of the relevant stakeholders to deliver the executive vision. When deciding on your management strategy, you must look at the future and have a vision of what that can be. A 5-year strategic plan should be completed for medical devices investment that links directly to the long-term operational plans or aspirations of the organisation. Look to 2025 and decide what technology your organisation really requires to deliver its transformational goals. These plans need to support the aspirations of the board and should be ambitious. They must be aligned with the medical devices policies because the policies direct the expected professional practice. It is important to work with the stakeholders to ensure that they understand changes in policy and therefore expected changes in practice. In my experience, the best way to do this is to deliver training on the policy and follow up with audits to ensure that policy goals are being embedded in professional practice. Actively support the delivery and work with the stakeholders to ensure that implementation and then ongoing operational commitment. It is very easy for stakeholders to revert to the way they have always done things, so monitoring and reporting will be a key element to successful implementation. You will definitely need board level buy-in if you are expecting to make transformational changes that impact on professional practice. Clinical data is extremely important when making decisions about how to treat patients. Manual entry of data wastes time and is often incorrect. This can lead to poor clinical decision making, and in the NHS, 99% of medical device data generated is currently not recorded or charted in the electronic patient record or trust IT systems where no EPR exists. It takes between 2 to 12 hours after collecting vital signs data from patient monitors before nurses enter it into the medical record. Documentation takes up to 35% of a nurse's time, 147 minutes in a 10-hour shift, and less than 20% of a nurse's time is spent on patient care and education. The manual entry of data leads to error rates of 17%. If clinical decision support software CDS is used, it is potentially reporting against this erroneous data. Only 7% of a nurse's time is spent on patient assessment and surveillance. 6% of patient lives are lost in ITUs because the data we record is transcribed incorrectly. This is the reality of doing nothing with the medical device data, making mistakes with the data, and if this carries on, more lives will be lost. So, making use of the data. Medical equipment data is a rich source of information that allows better clinical decision making, but only if doctors and nurses have access to it. It can also guide the senior management on where best to invest their funds to get the greatest benefits in terms of both clinical outcomes and financial efficiencies. We must firstly have accurate data, and the only way to guarantee accuracy is to automate the data transfer. The stakeholders can then use this reliable and accurate data to improve services, carry out better research, and help clinicians to make better decisions. Improving clinical decision support will ultimately improve the efficiency of the organisation, improve patient care, and reduce mortality. Part of any medical devices transformation plan must be to connect medical devices and medical IT into the electronic patient record to ensure clinicians have access to the data. This improves the clinical decision making and ultimately patient care. I just accidentally, sorry. Connected medical devices push data into the IT system, reducing errors and improving clinical workflow. I envisage that one day all acute hospitals will have a clinical data center that could be likened to an air traffic control center with artificial intelligence systems monitoring and managing all the data coming from the patients that are connected to medical technology, or even outside the hospital where patients can be connected at home. This control center will have trained clinicians and nurses that can use the AI feed to make decisions about treatment regimes, what drugs to prescribe, and when to discharge. I believe 100% that this is how healthcare will operate in the future. The fact is, we can already implement most of this technology, and this scenario could already be in operation in our healthcare organizations, but only if the right stakeholders are engaged and a workable, funded transformation plan is drawn up. The use of AI in healthcare is already happening. We need to ensure that any strategic plan includes investment in AI if improving clinical decision support is part of the plan. The medical and nursing directors will support this type of investment, especially when it can provide 100% accurate data for clinical decision making, allowing better clinical workflow and smarter early warning systems. Once the medical and nursing directors are on board, the rest of the executive team will drop into place. One area that has been particularly important during this COVID pandemic is remote consultations with patients, thereby avoiding infection risk. Remotely operating medical services can be expanded further to allow remotely monitoring of patients, freeing up of beds, and avoiding cross-infection. Telehealth also reduces the number of emergency ambulance calls because the patient's vital signs can be seen by both the patient, allowing them to feel reassured and probably not dial 999, and the doctor, allowing them to make improved immediate clinical judgments. This could also mean that the patient gets sent an ambulance rather than calling one and gets into hospitals sooner and so able to recover more quickly. When I started out in my career in the 1980s, Asset management was about recording the individual items around your organization and making sure it all worked. The main function being repair and maintenance. In the last 20 years, medical devices have become not only things you can touch, but also software components such as Health Level 7 or HL7, which refers to a set of international standards for transfer of clinical and administrative data between software applications used by various healthcare providers. Hospitals and other healthcare provider organizations typically have many different computer systems used for everything from billing to patient tracking. All of these systems should communicate with each other or interface when they receive information or when they wish to retrieve information, but at present, not all of them do. HL7 defines a series of electronic messages to support administrative, logistical, financial, as well as clinical processes. In the next 20 years, data in the electronic patient records, or EPR, will connect two software systems that use complex algorithms and software, in other words, artificial intelligence or AI, to emulate human cognition in the analysis, interpretation, and comprehension of complicated medical healthcare data. Specifically, AI is the ability of the computer algorithms to approximate conclusions without direct human input. The AI conclusions will be immediately available for the clinicians to review and enhance their own decisions about the clinical care provided to their patients. When I was a child in the 1970s, I would watch Star Trek on the TV, and the medical bay was complete science fiction. That is now becoming science fact. Clinicians have always used patient data to assess the condition of patients and decide on a course of action. In the 1970s, data was mostly written down on the patient notes, but medical technology has moved on. Medical technology is no longer about individual devices. It is about connected medical systems, where data can be immediately transferred accurately, and this accurate, fast data can be assessed by artificial intelligence, giving clinicians decision support about their treatment choices. These connected systems are not science fiction. They are available, and they will only become possible in all hospitals if executives, clinicians, and nurses really understand what we as engineers can offer them to support them to bring these systems and make sure that they operate in the way that they currently can. At present, medical technology is moving much faster than most healthcare organizations realize. It is our job to understand this connected systems approach and then provide support to enable faster implementation. Eventually, this new connected systems approach will be adopted by all healthcare organizations, but there are many reasons that they will slow down the adoption of these systems. These reasons can be arrogance from stakeholders who do not want change, and financial stakeholders who do not understand the long-term investment benefits. But on the positive side, clinicians and nurses want to get rid of the bureaucracy and want clinical decision support. It improves their decision-making, efficiency, and ultimately it improves clinical care. A helicopter view of a plan may look something like this. A 5-year strategy linking devices into the EPR, then linking data into the AI platforms. In year 1, it is vital to create a medical devices management policy that is aligned with the aspirations of the organization. In this example, that is to have an integrated system that supports clinical decision-making. The policy that you produce must be inclusive of all key stakeholders that will be on this 5-year journey. These will include the chief executive and board of directors, outlining responsibilities, and the directors responsible for medical devices, as outlined earlier in my presentation. I would envisage a two-tier approach within the policy, with the exec team being on the top tier responsible for ensuring strategic vision within the policy, and a middle management tier responsible for the day-to-day operational compliance. The tier 2 stakeholders would include clinical or biomedical engineers, procurement, clinicians, nurses, IT, estates, etc. In year 2, the organisation would need to implement the connectivity programme, which would include an HL7 compliant gateway management system to connect medical IT and electronic devices into the electronic patient record. This will improve clinical workflow and patient outcomes. In year 3, the data should be available for analysis, with the outcome of delivering service improvements. These integrated systems could be developed into areas such as patient surveillance, research, clinical decision support, and leveraging data for operational and clinical audit, allowing senior managers more detailed insights into the activities of their organizations. In year 4, connectivity could be applied to devices outside the organization, for example, in patients' homes. This would allow clinicians to monitor patients remotely, freeing up valuable bed spaces in the hospital. This is called telehealth and has the support of Matt Hancock, the Health Secretary. In year 5, the organisation will have reached its 2020 vision of a connected healthcare organisation with improved management systems, improved clinical data, and improved clinical outcomes. This slide shows a typical system deployment, with data being pushed from the healthcare technology into the gateway management software, where it is processed for transmission to the electronic patient record. This is an instantaneous process with 100% accurate data entry. The data can then be used confidently for clinical decision support, clinical research, and finally pushed into the AI-supported intelligent systems. A small number of NHS trusts are already implementing this type of system deployment, but most haven't yet started. If we can help our organisations to understand the benefits of connectivity, then we can deliver better patient outcomes, become more efficient, and deliver improved care. I often hear the expression, cost is king. I would disagree. In today's healthcare world, connectivity is king. Thank you. That concludes my presentation, and I will now have a look at the questions on the chat and see if I can answer a few of your questions.
Thanks for that, John. We haven't actually had any questions posted yet. We had, I think, maybe 5 or 6 in the first edition of the webinar. So if anybody does have any questions, please do pop them in the chat box quickly and John can get back to you. Thanks very much for your presentation, John. We will be looking to bring in the next edition of the EBME webinar series over the next few weeks. Just to highlight again what I mentioned before, that the webinar was recorded and the recording of John's presentation will be sent out to all registered participants from both this edition of the webinar and the previous one a fortnight ago. That will also be with a quick feedback sheet that we'd be very grateful if you could take a moment out of your busy schedules to fill in and get back to me. Just a quick reminder, as John mentioned before, that the EBME Expo will be taking place on the dates of 30th of June and 1st of July 2021. I think we do have a couple of exhibition stands remaining if anybody's interested in exhibiting. John, I can see the questions are coming thick and fast to you now, so I'll hand back over to you.
Okay, well, thank you everybody for coming to this webinar. It's new to me as well. It seems a bit strange sitting here in front of a computer without the traditional audience that I'm used to. But thank you very much. I look forward to more of these presentations coming from EBME Expo, and I look forward to seeing you hopefully in Milton Keynes in June next year. There are no more questions, so we will conclude there. And yeah, finally, thank you very much for everybody that joined, and goodbye. Oh, I've had a question, sorry. I'll have a look. With an increased number of cyber attacks, so this is from Carla Wood. With an increased number of cyber attacks, the concern is when connecting up the data safely. Well, Carla, the important thing about this is making sure that your software partners have the right levels of security within their software. So when you're choosing to move the data from the equipment to the EPR, there'll be interface software. And there are a number of different interface software providers on the market, and it's about making sure that you and your procurement team choose the right software with the right level of security that will hopefully then avoid having cyber attacks that could possibly get to the EPR. I've also had a message here from Heidi. Amazing, interesting topic and great speaker. Oh, thank you very much, Heidi. There's a lot. Hang on, I'm just going to expand my chat box because there seem to be more messages coming in. Well, Heidi said very eye-opening information, but also shocking about all the patients we lose due to faulty equipment. Yes, I agree. It is very shocking. And if this happened in the airline industry, I think a lot of airline companies will get closed down. I think we must be doing more with data. And as Carla pointed out, it must be done safely. Jake Bishop, hi, we have an asset management software product that manages equipment, locations, preventative maintenance, and equipment calibration. How easy is it for trusts to invest in additional software like ours after some of their past failed implementations? None of this is easy, and I think that's why many NHS trusts could have already done this. If you look at the Royal Free and Cambridge, they're a long way down this road. That's because they have invested, they've brought in the right skills and the right people, and they've involved the right stakeholders. So bringing in new software is always a challenge. The traditional asset management products don't do everything they need to do to be able to connect the data into the EPR. So that means bringing in more software products. I think it's a case of going out into the market, speaking to these companies. One of them is called Capsule Technology. That's not the only one on the market, but you can look them up on the internet. Capsule, C-A-P-S-U-L-E. They offer quite a good solution for connecting medical equipment as a middleware provider. Singh, really enjoyed your presentation. It was fantastic. Thank you, Singh. Kind of you to say that. Hi, John. What challenges do you expect during implementation and live phases? The biggest challenge is getting started. I think many trusts want to do this, but they're not sure how to get the money, number one, and then what to do with the money when they have got it. And often money disappears into capital equipping black holes. It's a case of having the right people leading. And I think that you definitely need the medical director and the finance director involved in this to make it work. It also needs the clinical engineering or the EBME departments to be involved in this, because traditionally it's not something that clinical engineering and EBME have been involved with, but neither has the IT department. It falls into a gap, and that slows things down as well. That's the biggest challenge, is who's going to take the lead in terms of the operational side of things, and who's going to take the lead in terms of the strategic management. Now, the strategic management needs to be the chief exec, and the operational needs to be a mixture of stakeholders, which will include procurement, EBME, or clinical engineering, and the nursing and medical staff as well. It would require a bigger, probably your medical devices group. Sally says, as we move towards having more telehealth, do you feel that EBMEs will need greater foundation training in IT related fields? Absolutely, Sally. Many of us come from a purely engineering background and had to learn IT related issues later on. Similarly, where does the line between EBME and IT get drawn? Yeah, this is, I'm not sure I can answer this question. It's a conundrum. I have been recently to a trust to give advice, and the EBME and IT departments, neither of them wanted to take the lead. So I think it's a case of, it's about leadership then. It's about the board saying, well, we're going to have to review our technology management. It may involve, as some hospitals have already done, bringing EBME and IT into the same department and having a lead. I'm not sure if I'm pronouncing this correctly. Hemapriya or Hemapriya. When AI is used, what about the cost factor for implementation? The UK government at the moment has put in £250 million to move towards more connected care. So it's about making sure that the hospitals have access to that money, and then breaking down what are the most important things for each organisation and what their specialities are. You can't bring everything in at the same time. That's why it needs to be strategic. It needs to be at least a 5-year plan, I would suggest, and then choosing your priorities and tackling it one strand at a time. You're not going to be able to go at this like a bull in a china shop. It's going to take a long time, and then there will need to be plans. It'll be about breaking it down into chunks and then deciding who's going to be responsible for each chunk. Gabrielle, I am curious about how long time until most of the medical devices are being used for the assessments of patients will be fully integrated into the EPR. Are medical device manufacturers according enough attention to integrated systems? The manufacturers definitely are giving enough time and ensuring that the devices can be connected. All medical electronic devices now have HL7, Health Level 7 software built in, so that they can be integrated into other software systems. And there are a number of middleware providers who can connect to the HL7 and transfer that data safely into the EPR. I think that's one of the important factors, is getting up to speed. Even myself, I'm advising on medical devices management and on developing some of these projects from where we are now, which is for some organizations not doing anything at all in terms of connecting medical equipment into their EPR. And in fact, many organizations don't even have an EPR. To, in 5 years' time, hopefully all organizations in the UK having an EPR and having a level of connectivity. There will be, I think, new people with new skills brought into the organization. Anybody that is a lot younger than me, so young engineers who are entering the profession or being not long in the profession, I think it would be something to focus your attention on. For me, I'm fast heading towards retirement, so I'm focusing my attention on this, but not because I want to do it as a career, it's because I'm very interested in it. But for people who are looking for a focus in their career, I think this will be really interesting, really rewarding, very good for patients, very good for organizational efficiency. And I think there will be, at some point, every organization will have a lead integration manager because there will be so many strands of integration. That's Gabrielle. Okay, thank you very much. I think I've answered all of the questions, so I think I'm going to stop it there and say goodbye. So thank you very much and goodbye.
Yep, thanks again, everybody. Again, just we'll send a quick email out with feedback forms and the recording of the presentation. But thank you for joining us, and we look forward to seeing you all again soon. Thank you.